Good afternoon, good evening to friends. Welcome to this WOC session on cataract surgery debates. I have with me my co-moderator, Dr. Gede Pardianto from Indonesia, and I am Dr. Mahipal Sachdev, Chairman, Medical Director, Center for Sight, New Delhi, India. We have a galaxy of speakers, and we will be talking about certain things which still evoke discussions and debates among ophthalmologists. And the format of this particular presentation would be that there will be two presentations, one talking on one particular aspect and the other ophthalmologist talking on the second aspect. And this will be followed by a 5 minutes discussion. So without much ado, we will move on to the first debate, and that is on multifocal intraocular lenses versus monofocal monovision in intraocular lenses. And the case for multifocal IOLs will be taken up by none other than Dr. John Chang from Hong Kong. And we all know that he's been trained out of Jules Steens, and he's one of the pioneers of cataract and refractive surgery in Hong Kong, and has been the past president of Hong Kong Association of Private Eye Surgeons. He's honorary associate professor at the University of Hong Kong and Chinese University of Hong Kong. So, without much ado, Dr. Chang, could you please share with us as to why you feel that multifocal IOLs are the way to go? Thank you.
Okay, thank you for the introduction. Very honored to be here today and I'm speaking the case for multifocal IOL. I do receive a research grant from Alcon and Zeiss. As you know, monofocal monovision has the advantage of a large choice of lenses. It is cost effective, is much cheaper, but binocular contrast sensitivity decreases with increase in monocular defocus in patients the anisomorphia, and you're relatively clear at two focal points only. So there's something there are always missing one focus. There's also a reduction of the function, and stereo acuity is decreased if it's more than 1.5 diopter difference between the two eyes. Now, Izumura looked at the stereo acuity and found that.
Sorry for interrupting. I hope you can hear me. Yeah. But I just heard that we're not live yet. We're only going live in 3 minutes.
So sorry,
I don't know. There is something going wrong with the timer that we see.
So Marla, yes,
it was going so well.
But it was a good start indeed.
Hi everyone, it's Marjorie with Phaco. Everyone's we had.
Well, sorry, guys. I eat myself,
We've got a little over 1 minute, 30 seconds to go.
No, just kidding. Okay.
It was going so well, but now we have had a good tryout.
Marline, are you good?
You can hear me, right?
Yeah.
Yes. So I think, do we need to refresh the page or anything to see the correct timer? Because I don't know what you're seeing. I see that we are already live.
We are not seeing any.
Yes.
Dr. Pardianto, would you wish to say right in the beginning something?
Yeah. Sorry, I didn't see a timer.
Would you wish to say something in the intro?
Hello, everyone. Can you hear me?
The indicator showing live here.
Is it?
Yeah. The indicator is showing live here.
Yeah, the camera here is showing live 56 minutes, 2 seconds. Are we live?
Yes.
So is everyone able to hear me?
When are we going live?
You have 52, 51, 50 seconds left, so you can feel that countdown. Since we're so close, I'll just say when you are in the chat, so everyone can look there. I have the timer going. If for any reason you want to refresh your page, you will see the updated timer. And we're at 30 seconds to live, everybody. I'm going to take my camera off screen again, but I will let you all know in chat when that timer goes to live. Break a leg.
This timer is showing 55 minutes, so I hope it's 60 minutes, right?
Yes. When we extend in the middle of a session, you won't see the updated timer until you refresh your page.
Okay,
I can give you and we've got 15 seconds to live. Break a leg.
Okay, great. Good morning, good afternoon, good evening, friends from across the world, and happy to have you join this session of the WOC on cataract surgery debates. I am joined as a co-moderator by Dr. Gede Pardianto from Indonesia, and I am Dr. Mahipal Sachdev, Chairman and Medical Director, Center for Sight Group of Eye Hospitals, India. We have with us a galaxy of speakers who will be debating on surgical debates that still exist in ophthalmology in the field of cataract surgery. And we have three sets of such debates, and each speaker will be giving his talk for 7 minutes each, and then we'll have a discussion for 5 minutes. So, without much ado, we go on to the first topic, and the first topic debate that is there is the case of multifocal intraocular lenses versus monofocal monovision. And we have none other than Dr. John Chang from Hong Kong. We all know Dr. John Chang is trained in ophthalmology at the Jules Steen's Eye Institute, UCLA. And he is the past president of Hong Kong Association of Private Eye Surgeons and honorary associate professor of University of Hong Kong and Chinese University of Hong Kong. And we all know he's a great cataract and refractive surgeon with excellent expertise in the surgical field. Dr. John Chang will be talking about the case for multifocal intraocular lenses, and I will request him to please share his screen and give his point of view as regards the multifocal IOLs being the best for cataract patients.
Thank you, Mahipal.
Yeah.
Can you see my screen?
Yeah.
Okay, great. So I'm here today to speak for multifocal IOLs. I do receive lecture honorarium and research grant from Alcon and Carl Zeiss. Now, as you know, monofocal monovision has the advantage of a large choice of lenses. It is cost effective, it is cheap, but binocular contrast sensitivity decreases with increase in monocular defocus. Patient may not like the anisometropia, so you must show that to the patient before you start. And relatively clear vision only at 2 focal points. So one eye only see 2 focal points. Both eyes, I'm sorry. So reduction in binocular function, halo and glare may still be present, and stereo acuity is decreased is more than 1.5 diopters. Now, Izumura did an assessment and found that 100-second of arc is the lowest limit for useful stereo acuity. And Hayashi did a study on 35 bilaterally pseudophakic patients and induced myopia in one eye and found they defined successful monovision as mean binocular uncorrected near VA of J3 2040, binocular UDVA of 2025 or better, and stereo acuity less than 100-second of arc. And they found that minus 1.5 in one eye and plano in the other is the best for this criteria for monovision, monofocal. But the near is weak. You can have stronger near with a -2, but your stereopsis really drop. Now, so what do we do? Monofocal monovision is better or multifocal IOL? Well, let's take a look. Rodolph used Symphony and did bilateral plano, and only distance vision was better. Although with the monofocal monovision, intermediate was not measured. But for near, the monofocal monovision is better, especially if it's -2 and much less halo and glare. If you look at bifocal with Restore and the Technis bifocal, you still see that the monofocal monovision is the winner still, with intermediate vision better and less halo and glare. And the Restore and really just wins for the near, and spectral independence is not significantly better. With the Technis, yes, better spectral independence, but glare and intermediate. Now, what about trifocal? This is Panoptics. This is Physio trifocal, fine vision. Now you see the trifocal is the winner. So the thumbs up are the winners, and only glare in monofocal monovision is better. Otherwise, intermediate, near, and spectral independence is winner for the both trifocals. So now, what if we did monovision multifocal IOL? I know a lot of surgeons are doing that. The nice thing is if you use EDOF, you have less halo and glare, and yet you still perform better than the multifocal, the monofocal monovision, and you don't need as much in isometropia. We did 10 patients, mean follow 182 days, and the one eye is 0 and the other mean is 1.33, and halo score is very low. You can see 5 being most severe, 0 is none, 0.7, 0.3, 0.3. And mean overall satisfaction is 4.56 out of 5, 5 being very satisfied. And spectral independence rate is 90%. So we went a step further because some patients come back, they say, Doc, my nears is good, no intermediate, and I'd like to paint my eyelids and I want to, plot my eyebrows. So we did 21 subjects. We used the ZMB, which is a +4, and we did monovision on them. Non-dominant eye, we don't have to go so much anisometropia, mostly -1 to -1.25. So stereopsis is very good. And binocular UDVA 2020 plus, intermediate uncorrected 2025, and near 2025. So very strong all the way across. And no IOL exchange required. Stereo acuity, contrast sensitivity were within normal limits. And satisfaction score, again, 4.4 out of 5. Of course, the halo and glare is more than the symphony, but still 5 being most severe and halo is only 1. Okay, so and complete 100% spectacle independence. Now, the bottom line, obviously, is complete spectral independence. So let's do a little comparison right here. This is monofocal monovision. This is the complete spectral independence rate is 26% up to 77%. OU Symphony Plano 74%. So monofocal is comparable. OU bifocal has no intermediate, so it's still comparable with monofocal. But once you get into the trifocal range, we're talking about 92, 96, and at worst 77% is better, definitely, than the monofocal monovision with no loss of stereopsis at all. And bifocal monovision, strong near, okay, 100% spectral independence. And even with EDOF, I use the Symphony, and lately I'm using the Comfort, which is also an EDOF, and I do monovision and with minimal halo and glare. So is halo glare a big problem? That's the thing that's stopping everybody from doing that. Remember, halo only happens in dark environment, okay? In bright environment, it doesn't happen. So in patients who don't drive at night, they don't have any night activity or drive very little at night, I just recommend the multifocal IOLs. Now, Zhang did a ZMB 22 eyes, this is bifocal, ZCB 22 eyes, and this halo and glare score, 4 being severe, 1 being none. You can see at 1 week, the glare and halo score is moderate. And at 6 months, it really drops down to mild and none. So there is a neural adaptation, okay? Same with even the monofocal at first had some halo and glare, but obviously that goes down to none. And this is actually shown in an MRI scan study by Zhang, and they showed decreased activity in the brain initially for the adaptation. And so there's actually physical indication, proof of neural adaptation. Tashigawa and did a assessment on, again, with halo size, halo intensity, 1 month, 3 month, statistically significant improvement, 6 month, 3 months to 6 months, statistically significant with the Panoptics, and same with the Symphony, there is an improvement. And there's more improvement from 3 to 6 months than 1 to 3 months, okay? And therefore, multifocal IOL, monovision, less cost is monofocal, monovision, less, but you have to be careful with the elderly because with too much loss of stereopsis, they're easier to fall, and they're very delicate, and they may take longer to adapt, and not everybody can accept monovision. Whereas multifocal IOL, near acuity is great, intermediate is good now with the trifocal, high spectral independence, no loss of stereo acuity. You must wonder about halo and glare, and there is an increased chair time. You do have to spend more time talking to them. So in conclusion, trifocal performs better than monofocal monovision. Even monofocal monovision can have annoying symptoms. In a study by Wilkins, 18% can have annoying symptoms. And if patient want less dysphotopsia and can tolerate monovision, I use EDOF, either the Symphony or the Oculensis Comfort, up to 90% complete spectacle-free versus 31 to 77% monofocal monovision. Major disadvantage is cost, and patient must accept halo and glare. Thank you.
Thank you very much, John, for lucid presentation. We switch on quickly to Dr. Fuxiang Zhang, and we all know he's a senior staff member in Department of Ophthalmology at Henry Ford Health, and he's a great cataract refractive surgeon with special interest in refractive premium cataract surgery. So we have his recording. We can just play that, please. Is it visible?
That's good.
Good morning. This is Fuxiang Zhang, ophthalmologist, National Report Medical Group, Detroit, United States. I'm going to present monofocal monovision, one of the most commonly used modalities for presbyopia management. There's no financial disclosure. Contact monovision was first presented in 1958, and the IOL monovision was in 1984, more than 50 years ago, and still they're working. Why do we still use IOL monovision? Because we still don't have the holy grail, a true dynamic accommodating IOL. Last year, ESBCS did a clinic survey. They find about 51, they find trifocal implants and EDOF implants were the leading presbyopia correcting implants. But they didn't seem to include monovision, at least from online information I read. I wish they did. But let's look at 2019 ASCA clinical survey. There are about 27% of cataract surgery involved in monofocal monovision, but only about 10% use multifocal implants, almost 3 times the difference. At least 6 advantages of monofocal monovision in my impression and in my view. Number 1, vision quality is great with best possible contrast. Number 2, satisfaction is very high. Number 3, glasses independence is high. Number 4, complaints and implant exchange are extremely rare. Number 5, candidate selection is much wider. Number 6, lower cost. There are other advantages of all IOL monovision. All new EDOF lenses still need to have a mini monovision to help reading. Cross monovision is also very commonly used. IOL monovision will not disappear even if we have an ideal accommodating IOL because of great vision quality and affordability. Light adjustable lens was approved by FDA 4 years ago. It has lifted IOL monovision to a new level. Doctors as well as patients don't have to worry about how much separation between the 2 eyes before the surgery. The outcome and the vision quality have been fantastic. But we need to keep mind open. We don't want to just use the monovision. I started array lens in 1997, Restore 2005, both the same year of FDA approval. I've also used all FDA-approved premium implants in the United States. Keep trying new things, but I don't stick to them if they are not really better than the basic. In March 2011, we had a head-to-head comparison study published at GCRS. Actually, we find that monovision group did better than the multifocal implants group in terms of patient satisfaction. We also published our new book 2 months ago, The Art of Refractive Cataract Surgery for Residents, Fellows, and Beginners, which include all the premium implants in the United States as well as laser and aura. Monovision also seems to be ophthalmologists' first choices. A survey was done in 2016 by Dr. Grossman. He surveyed 97 practicing ophthalmologists. 45% of them would choose for their own eyes. Only 16% would choose multifocal implants for their own eyes should they have cataract surgery by that time. There was another study published in 2019 with 328 ophthalmologists and residents surveyed. 61% of them would choose monofocal implant for distance or for monovision. Only 9% of them would choose multifocal implants for their own eyes should they have cataract surgery by that time. Well, let's look at my own study, 10-year IOL monovision review. Had 194 patients involved. In terms of patient satisfaction, 97% of them choose I like it or I really like it. Dependence, 2% didn't need any glasses, 39% need glasses for backup only. For depth perception, only 0.5% had an issue when they didn't have glasses. For nighttime driving, 65% didn't need any glasses. And need glasses for backup only in bad weather or heavy traffic. For more information about IOL monovision, you can refer to our published book by same medical publisher 4 years ago, Pseudophakic Monovision Clinical Guide. Summary, despite the increase in availability in multifocal and EDOF IOLs, monofocal monovision still seems to be the most commonly used. It provides great vision quality and patient satisfaction. It costs much less than multifocal lenses. It fits developing countries well. We should not use monovision only, however. Science and technology advance. We also need to try. End of my presentation, and thank you very much.
All right. Thank you so much.
Yeah, thank you so much, Dr. Gede. We don't have Dr. Zhang joining us. Okay, Dr. John Chang, what do you feel as regards your experience with the latest generation of the trifocal lenses as regards trifocals versus CRVs versus EDOFs? What would be your choice today, or would it be situation specific as regards the patients?
First of all, I talk to the patient and ask them what they work and their hobbies. Do they spend a lot of time nighttime outdoors? Do they drive at night? Things like that. That's the key, because I give my multifocal IOLs. First of all, I want to say also, over 90% of my patients now get a multifocal IOL of some sort. So if they have no problems with night vision, they don't spend, like in Hong Kong is very successful with trifocal IOLs because most people don't drive and they don't go outdoors at night. And they're always indoors. They play mahjong, they're singing karaoke, and it's all bright environment. So there's no halo problems. But if somebody were to drive and spend a lot of nighttime, then I would do EDOF monovision. The Symphony is good, as I showed you in my talk, very low halo and glare. Another lens I use is the Comfort Oculentis, which I mentioned as well. Also very, very little There's no glare and very little halo. It's just I tell them they may have angel wings when they look at night lights at night, but the comfort is only plus 1.5. If you go up to, they have different levels. They go up to plus 3, even higher. Then they really start having some dysphotopsia. For the plus 1.5, there's hardly any. So that's sort of what I do. If they have night vision problems, if they drive at night, I use EDOF. I do some monovision. The nice thing about the EDOF is you don't have to do so much anisometropia. You don't have to go to -2, one eye, and 0 in order to get strong near. Even at plus 1.5, still within the acute stereopsis level, and they still have strong near vision and good distance and intermediate vision.
Thank you. Dr. Pardianto, would you have any questions for John or Dr. Zhang? We cannot actually have them.
This is just a little statement from Professor Mary Jose Tassignon. She said that I think real accommodative IOLs will be little chance to work due to change of the vitreous and anterior interface. Maybe you have some opinion, Dr. Chang.
Oh, I mean, the accommodative lens is the holy grail. When that works, everything else is gonna thrown into the bin. So far, I look forward to the real or at least that works somewhat. I've been disappointed with the accommodating IOLs that are present right now. Nothing has really seemed to work very well. Either that or it's very difficult to put in. There's a lot of new stuff, but it hasn't really proven itself. But I certainly look forward to that. Yeah, I mean, that's the way to go.
Okay, thank you so much.
Thank you. I think joining in, so we can move on to. Thank you very much, John and Dr. Zhang. We can move on to the next topic. Thank you. And the next topic that we have for discussion is on another, I would say, another hot and new topic, I would say, over the last couple of years, and that is ISBCS, or what stands for Immediately Sequential Bilateral Cataract Surgery. And we will have the case for ISBCS being presented by Bita Manzouri from UK, and I can see her here. Dr. Bita, welcome. And we all know that she's a consultant corneal and cataract surgery and the immediate past lead for the eye casualty at the Queen's Hospital in Romford, and she's graduated from the University College London with first-class honors. Over to you, Dr. Bita, for your case for ISBCS.
Thank you very much. So I'm just going to share my screen, and hopefully you can see the presentation. So thank you to the committee of the World Ophthalmology Congress for the invitation to speak today and to present to you the arguments in favor of immediate sequential bilateral cataract surgery, ISBCS. So what do we know? We know that cataract surgery is the most common surgical procedure worldwide, with excellent outcomes with modern surgical techniques and biometric measurements. But the most feared risk is endophthalmitis, and it is this fear that feeds the belief that the two eyes should not be operated on at the same time. But we have problems. What are those problems? Well, cataracts are on the increase with an aging population that's living longer. Resources are limited, and we have to prioritize what resources we have and use them efficiently. And this is where ISBCS can deliver. So I'd like to present the arguments for ISBCS being the next evolutionary step in modern cataract surgery, maximizing patient satisfaction with minimal risk. And I'll support this argument by showing you the advantages to the patient, advantages to the healthcare provider, and advantages to the paymaster. So let's look at the typical pathway for delayed sequential bilateral cataract surgery. In other words, when one eye is operated on at one time. The patient is referred. They have a clinic appointment with possibly pre-assessment at the same time. A first admission for first eye surgery, a second clinic appointment for the post-op check and possible listing for second eye surgery, admission for second eye surgery, and a final clinic appointment for the final post-op check. And compare that with ISBCS, and you can see straight away we have eliminated 2 of those steps, thereby increasing your outpatient capacity. In ISBCS, we have 1 referral, 1 consultation with 1 preoperative assessment, 1 visit for surgery, and 1 postoperative clinic visit, resulting in no binocular imbalance between the eyes in between the ocular surgeries, and consequently 1 visit to the optometrist needing 1 pair of new glasses. So you can see that this already has clear implications in terms of health economics and outpatient capacity. So let's expand on this. The advantages to the patient. You have faster visual recovery, and a rapid visual rehabilitation is especially beneficial in patients who receive multifocal lenses because it supports that process of neural adaptation. And the advantages are even greater for patients in whom anisometropia is predictable. You have increased convenience, a return to work faster, reduced travel time, and reduced time off from work and from your hobbies, and less reliance on social support. And this, in addition, translates to reduced carbon footprint, which is very important in this modern era of sustainability. ISBCS is also convenient for those who need a general anesthetic or who have medical comorbidities, as it bypasses that need for a second anesthetic and its associated risks. What are the advantages to the surgeon? Well, they have enhanced job satisfaction due to their patients' rapid visual rehabilitation, and there's certainly greater operating room efficiency. One study showed that ISBCS yielded approximately 15% greater efficiency. And if you put that into practical terms, on a list of, say, anywhere from 6 to 8 patients, this efficiency would enable you to perform an operation on 1 extra patient. Now, I accept that payers are diverse. They may include state organizations, insurance companies, and even self-paying patients in a private healthcare setting. It is documented that compared with delayed second surgery, ISBCS reduces cost per patient, the exact amount depending on the methodology and setting. And no studies have suggested increased costs with ISBCS. And because payers are interested in thousands or hundreds of thousands of procedures, the total savings will be significant. Now, I'd like to just debunk some of the against arguments. The major risks that are often presented by antagonists of ISBCS are the risks associated with certain sight-threatening complications, such as endophthalmitis, toxic anterior segment syndrome, or refractive surprise that affect both eyes. The theoretical risk of simultaneous bilateral postoperative endophthalmitis with proper aseptic technique and the use of intracameral antibiotics is estimated to be less than 1 in 100 million. The critics of ISBCS always make the assumption that the end result of endophthalmitis is blindness, so that if a patient has bilateral endophthalmitis, they will end up bilaterally blind. But in reality, approximately 1/3 of patients who develop postoperative endophthalmitis actually regain driving standard vision. As for TAS, this represents a preventable system failure. This usually occurs when something has changed in the surgical protocol, either the source of balanced salt solution, the brand of gloves used, the detergents used for cleaning the instruments. However, the guidelines of ISBCS were specifically designed to minimize this risk, which, unlike endophthalmitis, is not a random chance event, but a preventable event. And as for refractive surprise, adjusting the second eye intraocular lens power based on the first eye result is controversial, and it is not completely clear that it is beneficial in average eyes with modern generation formulae. What we do know is that effective lens position is a major source of prediction error, so surely one surgeon, one technique at the same surgical sitting is better. So what one must do to practice safe ISBCS, and I think the most important take-home message from this slide is that the most important principle in ISBCS is to treat each eye as an individual autonomous procedure. Nothing in physical contact with the first operated eye should be used for surgery on the second eye. The surgeon and the team must re-scrub and change gowns and gloves, and a separate instrument cart preferably with a second scrub nurse from a different, with the instrument card having instruments from a different sterilization cycle must be used. So that you have anything that enters the second eye coming from different manufacturers or bearing different batch numbers from what was used in the first eye. So in conclusion, I hope I've presented valid arguments, 4 arguments as to how ISBCS has several advantages for the patient, for the physician, and the healthcare system. I truly believe that ISBCS should become the preferred option for the majority of cataract patients and is the right approach to the challenging climate of limited resources, yet increased need for ophthalmic care. Thank you for your attention.
Hello. Thank you, Dr. Bita Manzouri. The next, Mahipal, do you copy? Mahipal, do you copy? The next 7 minutes presentation, Jose Tassignon from Antwerp, University Hospital, Belgium, with the title, The Case Against ISBCS. It will be a recorded presentation. Professor Mahipal.
Financial disclosure.
Okay.
My name is Jose Tassignon, and I'm very happy to participate in this symposium on the immediately sequential bilateral cataract surgery, and I will present the case again. Here are my disclosures. I have a consultancy agreement with TIA and with Zimmer. I have a financial disclosure with regard to the intellectual property ring caliper license to Morture, but I have nothing to disclose with regard to this presentation. The case that I would like to present is a 59-year-old lady who was myopic from the start. She was -16 and -18. In 1990, she got implantation of phakic artisan IOL both eyes, and in 2000, she got a retinal detachment in her right eye, which was operated successfully. She was referred in 2022, really very recently, with decreased visual acuity due to cataract. Visual acuity was decreased, partially due to cataract, also due to the myopia. She mainly had quite important astigmatism. Now let us look at her biometrical parameters. She has 32.15 right eye, 31.65 left eye, outlier. That's the reason why it is in red. Astigmatism is also outlier. That's also the reason why this is in red. The keratometry decay mean is in fact within the norm. Anterior chamber is also within the norm. Lens thickness is a little bit borderline. So quite some outliers only based on the biometrical parameters. When you look at the pentacam, she has a regular astigmatism on the right eye and irregular astigmatism on the left eye. The posterior astigmatism on both eyes is 0.7, also a little bit an outlier. Orthoptic examination is quite normal, no strabismus, small exophoria as expected, no suppression, poor fusion, but stereopsis was still present with reading glasses. When we look now at the endothelium, it was surprising to find that the right eye presented a quite poor endothelial cell count. Large cells, really active because cornea is still transparent. The other eye is absolutely normal in number of endothelial cells and quite important and quite big number of cells present. Don't forget that that eye, the right eye, had a retinal detachment in the The macula, there is no macular degeneration related to the high myopia. There is a little bit of staphyloma, but not very pronounced. And there is, of course, a thinning of the retina and pure pigmentation, I should say, not thinning of the retina, pure pigmentation of the posterior part of the retina. Now, when you conclude, there are here several parameters that or conditions that will decrease the precision to calculate the intraocular lens. We have only regarding the biometrical parameters, we have 3 outliers. We have an irregular astigmatism. We have a combined surgery that we have taking away the artisan lens and performing the cataract surgery. We have a compromised endothelium in one eye, and we aim at keeping a mini monovision like her eye, like she was used to. So I don't think that this is a case that you can do simultaneously. I thank you very much for your attention, and I thank you again for your invitation.
Thank you so much, Professor Marie-Jose Tassignon from Belgium. Incredible presentation, Bita and Marie-Jose, so fantastic. And fellow ophthalmologists, now we are approaching the 5 minutes discussion session. I check the chat.
Maybe I can comment on the accommodation that we spoke a little bit earlier, or my comments. I think that it is very important to know nowadays that real accommodation is prohibited by the fact that we have vitreous liquefaction first, but that we also have by aging a detachment of the anterior hyaloid. And this detachment of the anterior hyaloid will, of course, decrease the support of the lens by the vitreous. So that means that the capacity of the lens to contract and the forces of the induced by the ciliary body will really be reduced by aging. And I think that that is one of the biggest reasons why real accommodative intraocular lenses will may be possible for children and young adults, but not for the other patients, I'm afraid. But that's for the real accommodative intraocular lenses. And that's the reason why I more and more believe in EDOF lenses, mini monovision EDOF lenses, for the normal range of biometrics. And that is important. And that's the reason why I want to stress this presentation, is to really recognize the outliers in biometrical parameters, and of course also on the remaining of the eye, also the retina, also the pigmentation, etc. These are, everything was present in this specific case, and that's the reason why I chose that patient.
I have a question to Dr. Bita Manzouri. Do you have any experience to do ISBCS to patient that require extremely fine vision like pilot?
I'm sorry. Do I have experience in a patient who requires? I didn't catch the end of that question.
Yeah, require extremely fine vision like a pilot.
Yes, I do, and you know, I think it's really important that you have adequate patient selection. When you have patients at the extremes, you know that the biometry may not be as accurate. So perhaps in those cases, ISBCS is not indicated. But again, with greater experience as an ISBCS surgeon, you can even counter the effects of less accurate biometry. But I have had several patients through the 7-8 years that I've been doing ISBCS, patients who require very good vision. And as long as you do meticulous measurements, you consent the patient appropriately, we haven't had any problems.
So, Dr. Bita, are there any exclusions that you would wish to say as the guiding principle, that these are the patients where you would not do simultaneous surgery?
You know, there are some, and I would say the list is longer for the novice ISBCS surgeon, whereas the more experienced ones tend to be able to counter some of those. So perhaps for the novice ISBCS surgeon, you would perhaps not do ISBCS on someone who's got corneal pathology, someone who's at high risk of retinal detachment, but even those circumstances can be mitigated against. So someone who has some corneal pathology in the form of guttata, you would use good viscoelastic devices, low flow phaco. Some people say don't do ISBCS on patients who have glaucoma, but again, we know that the act of cataract surgery actually reduces the intraocular pressure in patients. Stephen Arshinov, who is probably one of the lead, or who is the lead ISBCS surgeon in the world, his exclusion criteria are essentially patients who have subluxed lenses, luxated lenses. You know, he's really narrowed down the exclusion criteria based on his experience. So I think there are certain patients that are not suitable for the novice ISBCS surgeon, but as you gain experience, that list becomes smaller and smaller and smaller.
Professor Merrick, would you wish, because as can this lead to a potential litigation in case of complication? Because in countries where it is not considered as a standard of care that you do bilateral simultaneous surgeries, if there are problems, can that for an ophthalmologist till such time that it is made standard of care lead to potential litigations?
Yes, indeed, that's correct what you say. It is indeed correct. Like Bita says, everything depends a little bit whether you have you are a novice, a bilateral simultaneous surgeon or not. But nobody record that, and that is a little bit a problem. Who knows what is your experience on that? And we have no database on that. In most of the countries in Europe, for example, it is the case in the Netherlands. The Netherlands have put that all in a kind of a regulation matter, official regulation matter, and that is fine. But this is only the case in the Netherlands. It might be that is also the case in the UK. It is most probably also the case in the US, and then here and there you have countries that use it. Now, for example, what I do is certainly bilateral, and I'm doing that very long time already, the simultaneous bilateral cataract surgery. But what I certainly promote is to do it in children, because in all cases, let us say, in patients who are really mentally disabled, patient who cannot lay down, who needs general anesthesia, and also in children, because we know that the number of anesthesia in children is harmful for the brain and for the development of the brain. So I think that this is a very good argument to do it bilaterally.
Yeah, and if I may just add, in addition to that, in the UK, since COVID began, the Royal College of Ophthalmologists, along with the United Kingdom and Ireland Society of Cataract and Refractive Surgeons, have produced very clear guidelines as to which surgeons should be undertaking ISBCS on what kind of patients. There is the medical legal principle called the Bolam principle, which effectively says that you are protected against litigation if what you have done is what the majority of safe practicing ophthalmologists would have done in your position. So if you decide to do ISBCS and that on that patient, that was a valid decision that other ophthalmologists would have undertaken, then you are actually protected by law. But say you are a novice ISBCS surgeon and one of your first cases is a case of posterior polar cataracts in both eyes, and that runs into problems, then you would not be protected by law, because that's not what the majority of surgeons would have done on that particular patient.
Yeah. Thank you very much. We had a great discussion, and let us move on to the final topic for today, and that again is a learning topic. While those who do it consider it to be something that adds on specifically in complicated cases, and that is the femto laser assisted surgery. So the final debate today is the case for laser assisted cataract surgery. This is going to be spoken for by Tim Schulz from Germany. We have the Tim, please, Dr. Tim Schulz.
Thank you for the introduction. I start my presentation, just a second. Okay, I think everybody can see me now in the presentation. So very welcome from our holidays in Portugal, not from Germany today, but as you know, I'm based in Germany, and I'm very happy to present you our results of the last 11 years of research on femtosecond laser surgery and do the pro talk. I have financial interest. I'm a consultant for Johnson & Johnson Vision. I will bring up some basics and then go to special cases. And here's what you know already, what can be done with femtosecond lasers: capsulotomy, lens fragmentation, and corneal incisions. In our daily routine, we have 2 femtosecond laser in the hospital. It's the Catalyst Precision Laser System and the LensAR system. And I want to start with an important topic at the beginning. It's the docking. It is important that you have a good docking. Without this, you cannot compare anything. And it's possible with the systems I showed you in glaucoma patients. So we start with a capsulotomy. We did a lot of research on this. And maybe the main point of my talk is that the femtosecond laser is not a miracle machine where you push a button and get a perfect result. It's more like a new procedure or a surgical tool, like a special knife. With that, you can do special things, but you have to take care how to handle it. So you have to optimize many settings, and it's much more than maybe some of you know. And with the perfect capsulotomy, you have the perfect setup for a perfect cataract surgery, especially in premium IOLs. Just to remember how it works, we start in the anterior chamber, go anterior and cut the lens on our way up. What we did first, we measured the size. So the manual surgeon on the left was very good in the median, but as you see, it is not comparable to the femto. And here's some of the first raster electron microscopy images of the femto. You see it a little bit like a saw blade, but what I have to mention, you can have aberrant shots, and I will show you in the next slide. So what we do is we put OVD in every case, put it to the middle, so you have a free-floating capsulotomy in all the cases and avoid this, a capsular tear. What we saw is the patient was living, that is under the laser. So 99% of our surgeries are not in general anesthesia, so the patient is breathing, is moving, and that's where we found the tears, and this has to be taken in account in your settings and how you behave. So yeah, finally you have to talk to the patient and hold the head, have a fixation light, so there are many adoption options. The next thing we saw is the laser-induced meiosis. I did a lot of research. What I found is the laser is inducing release of prostaglandins, which you don't have in the eye if you do nothing. Then we looked with steps of the treatment it is the capsulotomy, and we were able to prevent it with 3 drops of prostaglandin, non-steroidal antiphlogistic inflammation drugs that block prostaglandins. The next thing is the lens fragmentation. Here, how you can do it in a wide range and different sizes and different patterns, and it helps a lot, especially in brown cataracts. I will show you later with the special cases. And we did a lot of other adaptations. We adapted our phaco tip, our bimanual, our settings. So there's a lot of work that had been done to get a good result with a femtosecond laser. And I just want to show again also the effectiveness. So we have reduced a lot the phaco energy in these cases, and we were able to show some advantages in regular patients for endothelial cell count, but I think they're even bigger in Fox industry cases where you do a very close pattern and can get out the lens. And the same is for the arcuate incision. So with the femto, you are able to reduce astigmatism, especially in the cases between 1 and 1.5 diopters, where maybe a toric IOL is not the best option because you don't have a clear axis. With the femto, you can handle more like a range where it can be. So we have the very good calculators for at the moment. But now let's go to my pro talk, because I'm so convinced that femto is the best option. It's the many outliers we have beside standard cataract surgery. I just visualized it a little bit to make it easier. So first we have the cases with corneal scars and bad corneals. It is not possible to treat this patient, but it is He just has to adapt the settings. The spot spacing needs to be closer, and you have to see your scars on the screen so we can maneuver it between the scars and treat them. It's the same for example, radial keratotomy, and also for small dot scars after an infection. And so you have to be careful, but you can treat them. The next thing is the brown cataract. So it's not only reducing phaco time, it's just to break the lens much more easy and get it out in 4 or 8 quadrants. And what we did in try, we saw that the energy is even much reduced with the femtosecond laser. The next thing is the case of small pupils or floppy iris syndrome. It can be done with the catalyst easily with the Mahipal ring, so you can do it under stereo conditions, go under the laser and swing forth and back with your microscope, so you can put in the ring, go to the laser and go back, and everybody knows how difficult it can be capsulotomy in these cases. Also, glaucoma patients are not a problem anymore because of our data. Some lasers are cleared for glaucoma patients, especially with this fluid interfaces. We have an increase in pressure, but it is not much more than what we have doing regular cataract surgery with a tip in the eye. The next hot topic for myself are the wide lenses with a high intracapsular pressure. Like you can see on the left up side of the presentation, we have these wide lenses, and nobody can tell me that anybody with any technique, it's possible to do them all well. So what we did first is we did a normal capsulotomy, and what we saw is it's exploding during the first shots, and we have aberrant shots. You can see it in a higher magnification on the right side. So we have many lines of the femto shots in the capsule, and you might end up with. So you have to be very femtosecond laser doing it like this. What we did is we developed a mini laser capsulotomy. It is a 2 millimeter capsulotomy. It's actually the smallest one you can do with a catalyst precision laser system. We cut it to get out the pressure like an explosion, and then we go back to the laser system and do a second one. We love to do it. We have collected many cases and are ready to present it, and the results are outstanding. Problem is, I have to mention this here, it's not supported by the company. It's an off-label use, and you have to pay 2 treatments, which is a problem actually. But the technique itself, it's incredible. Another point nobody discusses is that if you have a posterior capsular rupture, I know it's never happening, but if you have one, you have with a perfect anterior capsulotomy of the femto a very good option to do optic capture and have a good result finally. So I love to have this option in my cases. We have discussed it more beforehand. It's the pediatric cases. We have done now more than 100 pediatric eyes with the femtosecond laser. We have developed a formula, the so-called Bochum formula, which calculates the final diameter of the capsulotomy. So you can say, I want to end up with a 5.0 capsulotomy, and the formula says what you have to put into the laser because it's enlarging so much because of the high elasticity. And it's a perfect option to put in at the surgery or maybe years later back in the lens or something similar to get the best outcome for these small patients. The last thing is I want to highlight is capsule marks for toric IOLs. We all know that it is important to have the toric IOL in the correct axis, and whatever you're using on the cornea, you will have a parallaxy effect because the cornea is not the lens. And with this marks, for the first time, you have the option to have something on the lens. And there's one thing we learned over the last 2 years, a big advantage in this case is in comparison to all other biomorphometric systems. Do the lock-in of your eye in the surgery, you do it with a fixed eye. So we don't have any problems. And as you can see here, and registration. So as you can see here, we are not marking manual anymore. We have the USB stick, we put it in, apply, and it's always working. So I'm very happy about these options. So in conclusion, we have this excellent techniques with this new surgical tools, mini capsulotomy, posterior capsule defects, pediatric cases, and toric IOLs. We have good help with the laser and brown lenses, small pupils, and glaucoma. And we have to be careful with corneal stars and white cataracts. white cataract is a mini capsulotomy, as I mentioned. So I want to thank you very much. If you want to see some of these techniques, we made a book together with Time, with my boss, Professor Dick, and Ronald Gerste. It's available in English and in Portuguese now. So thank you so much.
Thank you very much for your presentation. And can we have Dr. Cedric Schweitzer for speaking against and saying that conventional Phaco is good? So he's going to talk about conventional Phaco. He's from France and he's going to make his presentation. Dr. Cedric, please. He's a glaucoma specialist working at the Bordeaux University in France.
Hello, thank you very much, dear colleagues, dear committee. So I'm going to talk about the case for conventional Phaco. So, who has not been impressed by this innovation, enabling capsulotomy, corneal incision, and Phaco fragmentation in less than a minute? On the other hand, we should also acknowledge that Phaco emulsification cataract is for patients. So I'm going to show you that FLACS is not superior to Phaco today. Current evidence about Phaco emulsification showed that the overall complication rate in Phaco emulsification range between 4 and 8%, and the most frequent intraoperative complication is posterior capsule rupture, and the most frequent so it was intraoperative, and the most frequent postoperative was cystoid macular edema. This US audit performed in approximately 50,000 Phaco emulsification cases observed 1.8% of posterior capsule rupture, and interestingly, they also reported the stage when it happened during cataract surgery. And they showed that it happened in 60% of cases during the Phaco emulsification phase, and in 24% of cases during irrigation aspiration phase, so not during femtosecond laser stages. This other interesting prospective cohort study performed on 1,600 FLACS procedure, analyzed surgical outcomes on videos, and they showed that FLACS is associated with additional complication, new complication related to incomplete capsulotomies, with 3% in 3% of cases, and leading to anterior capsule tears. And the main causes were eye tilt and intracameral bubbles. So what about visual and refractive outcomes of Phaco emulsification cataract surgery? So we observed significant improvement in Phaco emulsification with 72% of the eyes achieving a refractive error below 0.5 diopters, and 93% achieving refractive error below 1 diopters in recent cohorts. In the European, in this large European database, they also analyzed main clinical predictors for complication and main clinical predictors for bad visual and refractive outcomes. And it was related not to the surgical procedure by itself, but it was related to ocular comorbidities, poor preoperative visual acuity, and any intraoperative complication, of course. So although circular capsulotomy significantly improve overlap of IOL ages, the way femtosecond laser capsulotomy significantly improve the IOL positioning within the anterior chamber still remains unclear today. What about complex cases? We should also acknowledge that a femtosecond laser is still limited by some ophthalmological conditions, particularly in small pupils, limiting the performances of the laser. In case of IFIS, with a high risk of constriction during suction phase, and limited also by corneal opacities and by radial keratotomies. And in a recent paper, it was reported that there is a high risk of keratotomies rupture during the suction phase. So our femtosecond laser compares objectively with Phaco. So we published a multi-center randomized clinical trial comparing clinical outcomes between femtosecond laser and phacoemulsification. And this was also a cost-effectiveness trial. And we showed that by far there was no significant difference between FLACS and Phaco in the 4 clinical outcomes we defined in our clinical trial. And these were the overall rate of uncomplicated surgery, best corrected visual acuity at 0 logMAR or better, absolute refractive error below 0.75 diopters, and significant change in corneal astigmatism. And when combining these 4 outcome measures, again, the overall success rate was not significantly different between the 2 surgical groups. Interestingly, we also showed that whatever the cataract severity grade, as assessed by LOCS, the LOCS scale, there was no significant difference again between the 2 surgical procedures. The 2 other large randomized clinical trials reported in the literature, the FACT trial and the St. Thomas's trial performed in the UK, also did not show any significant difference between femto and phaco. And interestingly, visual acuity and refractive error were fairly comparable between these 2 large trials and were comparable with registers published in the literature. And last but not least, we should also acknowledge that health resources need to be consumed in order to improve health benefit. And phacoemulsification cataract surgery is associated with the best cost-utility ratio in surgery worldwide, and which is comparable to hip surgery or defibrillator implantation. FLACS today is associated with additional direct costs related to the laser, patient optic interface, and some other related to patient journey with additional staff or additional rooms to perform surgery. In the FEMCA trial, we showed that the probability FLACS was cost-effective in this bootstrap analysis was only 6.7%. And we also show that whatever the willingness to pay per additional patient for treatment success, the probability FLACS is cost-effective never exceeded 15.7%. So in conclusion, despite high precision, there is no evidence FLACS improved health benefits for patients. And it's associated with additional cost and is time consuming. So when considering the worldwide burden of cataract surgery, as assessed in these Lancet papers, Phaco remains a fast, efficient, and cost-effective procedure to treat our patients every year. Thank you very much.
But thank you very much for your kind presentation. My question to you is that there are a lot of studies that you have reported. Would it be good to also compare the outcomes of FLACS versus Phaco in that Tim mentioned about?
Yes.
To talk about, say, white cataracts, subluxated, hard cataracts, those kind of situations that were shown as difficult cases?
Yes, we did. We did it on white cataract and brown cataract as well. And there was no significant difference, even in endothelial cell counts. And we did not perform it on small cataract and not on pediatric cases. But the cases we did in our surgical trial were fairly representative with the current practice in France, and we included a wide range of cataract surgery and type of patients in our clinical trial. It was a kind of real-life cataract surgery trial.
Okay, and would you think the results will be any different between trained phaco surgeons and a novice phaco surgeon versus a novice or a learning femto surgeon?
That's a very good question. And we had 20 surgeons in our trial, and we wanted to include surgeons who were highly experienced and younger surgeons. And after the 20 initial cases, there was no significant difference between surgeons. So femtosecond laser is not associated with an important learning curve. but Phaco is not also associated with a very significant learning curve as well.
Okay. I see this. Can I respond?
Sure.
I see this totally different. As I mentioned, it's a surgical tool, and I think 20 cases is far away from being experienced with the femtosecond laser. I think you need maybe 1,000, maybe 2,000, better 5,000 cases to call you an experienced femtosecond laser surgeon, because it is not a miracle machine. It is a surgical tool. You have to understand in detail to use it and be successful with it. And yeah, as you mentioned, you put the border in your trial to 20 cases. So we have one center in the trial. So it's something like 12 surgeries for a surgeon, and yet then to mention, so it's a total different point of view on the topic if you use it like this. I think it was breast. And the next thing is what I mentioned, what has not been discussed and is not taken into account in many of the trials is astigmatism. We don't know how important it is. In the big French study, patients up to 1.5 diopters were, and astigmatism procedure done. So everybody of us will not do this. Wants to get a good acuity. So I'm a patient with a high astigmatism of 0.75. And there's a new trial out in the Journal of Cataract Refractive Surgery this month showing the good options of intrastromal and penetrating aqueous incisions, and especially in the cases with not regular astigmatism, I see the advantage of the femto. We don't have to cast about 3 diopters of astigmatism. There, I believe the toric IOL is much superior. I go for this case which were included in the bench trial but not treated.
Thank you.
Okay.
Dr. Gede, would you wish to have any final comments, because we have run out of time?
Can I have a question?
Yeah, yes, Dr. Fuxiang. Go ahead.
Okay. Okay. Hi. Sorry. Beginning it was blocked. I have a quick question for Tim. How can you manage the centration and the fixation for kids if you use general anesthesia?
Yeah, so we have the laser in the operating room, so we can do the procedure fully sterile. And for the catalyst, there are two interfaces available. One for it was designed for more Asian eyes with a small anatomical situation, and they're fitting with pediatrics. So in the first cases, when it was not available, we did a lateral cansotomy, but we didn't do this for many years now because it was always possible to get a docking with a small meter cord interface. And yeah, and then you can dock and do the regular procedure, but you have to take into account that your capsulotomy will get much this formula published where you can calculate it age dependent. And we are coming up with a new version of it, hopefully by end of this year, with more than 150 cases.
Thank you. Dr. Gede, any final comments before we wrap up the session?
Thank you. I agree with Cedric that substitution for Phaco. Anyway, Tim, your article in Journal of Refractive Surgery a few years ago about FLACS in Marfan syndrome was awesome, I think. Would you like to tell me the story, short story, please?
Sorry, I didn't understand. Can you repeat?
It's about your article a few years ago in Journal of Refractive Surgery about FLACS in Marfan syndrome. Would you like to tell me the story?
Yeah. Good option.
So as you know,
the lens will be decentered, and you have to be careful which laser system you have, because not with all systems you can move around anywhere with your capsulotomy. And what we did in the case, and what we did, I think 2 cases of Marfan this year, is to do the capsulotomy and then put in a Sioni ring, which is problematic at the moment because of the changes in Europe. It's not so good available, but we have still some, and you can fixate the lens with a very good result. I think published, but we did it also in adults, and I'm very happy to have this option because, as you all know, capsulotomy in Marfan syndrome can be very difficult. But be careful which laser you're using. I know that not all of them can freely move the capsulotomy.
Well, I think thank you very much. We had a great lively session, and obviously these are controversies that will still linger, and there'll be points, pros and cons for each of them. And I wish to thank all the speakers and my co-moderator and WOC for joining in this session and giving us this opportunity to talk about this. Thank you very much, and bye-bye, and thank you all the speakers. Thank you.
Thank you. Thank you. Bye.
Thank you, Mahipal. Thank you, Fuxiang, Cedric, John, team.
Bye.
Thank you so much. Bye-bye.
Bye-bye. Thank you.
Bye. Thank you.
Bye.
Thank you so much.